Herzlich willkommen zum Endoclub.
Welcome to EndoClub Spring 2017. We're going to show you a patient with long segment Barrett's esophagus and suspected low-grade dysplasia. Everyone's familiar with it. Someone appears at the practice or hospital with long segment Barrett's for biopsy, and then it turns out it's low-grade. And we'll go over now to Ollie Peck. You can see here from the cardial folds. Here's the junction, stomach. Here you see, to the Barrett's. And then you just go back slowly in white light mode. And you can see from the overview, first of all, if there's anything unusual in the Barrett's. So that means, what are you looking for? You're looking for irregularities in the mucosal pattern, nodular lesions, or also vascular abnormalities. Now, I would call this atrophic Barrett's. Why? Because when you look here, you can see lots and lots of vessels, and sometimes large submucosal vessels. Here, to show you the opposite again, you can see some epithelium that's a bit juicier, with the regular Barrett's structure on top of it. Can you see that? Yes. In contrast to the atrophic Barrett's, you can see the classic Barrett's epithelium here. And in principle, that's the difference between atrophic Barrett's and normal Barrett's epithelium, mashed. And here we can see the atrophic Barrett's epithelium, clearly different, with far more vessels visible. Here we've got another area with increased vascularization. It doesn't strike me as looking highly suspect. In the end, of course, you would take the area where you think it could possibly be something and then take targeted biopsies. Acetic acid staining. I'll position myself at the upper margin of the Barrett's here and introduce acetic acid through the working channel. The patient had quite strong reflux, so even 10 milliliters will probably be enough. That goes down the Barrett's segment and then comes up again. Now I'm suctioning the acetic acid out again so that the patient doesn't aspirate. Now we can take a good look at the whole thing. You can see here that the Barrett's is becoming slightly whitish, as if it was covered in icing. And that lets you see the surface structures better, what disappears slightly in the vascular structure. And here we can look at whether there are any areas in the Barrett's. Here we can see the surface structure of the Barrett's esophagus quite well. I'll switch near focus on again, and then NBI as well. And then you can actually see it very well. Can you see it all, Thomas? Yes, very good. Here you see it very well. The surface epithelium is much better visible now than with NBI alone. And in near focus after acetic acid, you can see it very well again. We're now at the lower side, and now we're going again to the upper half of the Barrett's where we saw those abnormal lesions. This is one here where we spent some time. The acetic acid effect here isn't as good as you'd want. But here the surface is also, well, you can't assess it properly, really. Maybe you could. We'll make the histology available, but we can note that spot. Maybe you could take a separate biopsy. I'll do a separate biopsy of that. As you can see, it's difficult. I think message number 1 would be, you can take a look at what's abnormal and take a targeted biopsy. Message number 2 has already come out. You ought to take step biopsies nevertheless. And message number 3, low grade is particularly difficult. Histological analysis showed high-grade dysplasia in a distal random biopsy. The biopsy of the suspicious lesion was histologically negative.